Um, Today we're going to talk about moving and handling. We have an eminent speaker, Jasmin George, who is a moving and handling coordinator working in Bristol NHS Trust. Moving and handling is vital part of nursing role on a day-to-day basis, along with other multidisciplinaries. It is the responsibility of the employees to make sure that you use the right technique in handling your patients on a day-to-day basis. It doesn't have to be just the patients, it is also to do with the equipments that you handle on a day-to-day basis. And it is equally the same responsibility of the employer to make sure that they provide adequate training. So this next hour of training, the webinar, is only going to provide you some information. It's not necessarily a comprehensive training, I would say. It's only an brief information for you to take this forward and perhaps discuss this with your employer and maybe arrange for further trainings. So over to you, Jasmin.
Thank you. Hello everyone. I'm Jasmin George, one of the manual handling advisor for University Hospital Bristol. I'll just share my screen. Okay, can you hear me? Can you see me?
Yes.
Yeah. I'm doing this job from 2008. I'm with the same trust. Okay, let us start. Moving and handling is a part of or working day for most of the employees, from moving equipments, laundry, catering supplies or waste, and to assist the patients. So poor moving and handling practices can lead to back pain and musculoskeletal disorders, which can lead to sometimes inability to work. Moving and handling accidents, which can injure both the person being moved and the employee, and sometimes it can lead discomfort and lack of dignity for the person being moved. So it is quite essential. People should be aware about what is the right practice, how to follow manual handling.
Okay.
Yeah, just next slide. Okay. Aim of the presentation to provide an understanding of provision of manual handling advice and training at an acute NHS Foundation Trust. And this presentation, I have to say, this presentation does not replace the need of practical manual handling, compliance training. As Tipe mentioned already, if we need any more, the people have to consider and they have to practice. They should be starting in their trust. Let me talk a little bit about our hospital. I'm privileged to work part of University Hospital Bristol, that is University Hospital NHS Foundation Trust and Western Area Healthcare Trust joined together as one of the outstanding organizations on 1st April 2020. Our newly emerged trust combined workforce of over 13,000 staff, and we aiming to deliver exceptional local service for local people and specialist service across the Southwest and beyond. Together, we form one of the largest NHS trusts in the country. And we have 10 different sites. So we like around more than 1,000 inpatients we have in our trust. And we manual handling team stay in under safety department. In our team, we have 6 of us working together, and main part of our job is training and advisory services. I will explain it a bit more later in another slide. Our team purpose to promote a safer, holistic, and evidence-based manual handling approach to protect staff from musculoskeletal injury and support patient safety. Okay, let us talk about a little bit about what is the need of manual handling and why musculoskeletal, like that is from HSC report. And the health and safety executives, they call us HSC, they're the national regulators, and even they, through them, we get information. As per HSC, the musculoskeletal disorders can affect muscles, joints, tendons, and part of the body. Most work-related injury develop as a cumulative, and sometimes that can be life-threatening. And HSC prefers self-reports from labor force survey. You can see in the screen that is the data from 2020, 1920. Last, and they are doing this every quarterly, and in that 44% of upper limb and neck disorders. So you can clearly think, and I'm sure you might be thinking, what is the cause of that? Mainly because of the posture. And 37%, that is a back injury. Now we have to think, what does the law say? There is a statutory requirement for staff to be kept safe at work. So our trust and HSC, they're trying their level best. The first one is Health and Safety Work Act 1974. That is a primary piece of legislation covering the occupational health and safety in Great Britain. It set up some duties for the employees and employers. State, there's a six-pack act law actually. You can say that as an umbrella act. The personal protective equipment we call as PPE. So it is essential for staff to use. Trust has the responsibility to provide, and staff have to use it. Sometimes when we are thinking about manual handling, when we are moving a patient, it can be quite difficult to wear PPE like gloves, masks, aprons, and perform safe manual handling. But we have to think about our safety and your patient safety. And workplace regulation, and in that provides information on the state of the workplace. For example, the lighting, ventilation, access to the facilities, and drinking water. The display screen equipment, we will be talking about that a bit more detail later. That is all related to the computer users and work equipment. The LOLAR and POWER, PUWER, that is one of the regulation just for helping the work equipment, that is provision and use of work equipment regulation that relate to all the equipment used for work tasks. It states the equipment should be all fit for purpose, and if there is a faulty, they have to report to the right people, and that have to check and make sure staffs are quite happy with that. And people who is using, they should be trained. If you don't know, then we should not use it. And LOLER, that is the one lifting operation, lifting equipment regulation. That is mainly for all the lifting and lowering equipment. So when it is coming to the hospital setting or even looking after a patient, we can think of a equipment called Hoist. So that is coming under LOLAR. So as per LOLAR, there is the responsibility for people should be provided with the right equipment, and even that should be serviced every 6 monthly. And each staff member has the responsibility to check and make sure that is working properly before they are going to use it. And management of health and safety, so that is all the risk assessments, and we have to perform the risk assessment before the task and make sure everything is safe. Okay, so next one is the manual handling operation regulation 1992, and that amended in 2002. So that is a manual handling regulation actually. So in that one, clearly saying, like I think that is one of the, that is clearly saying avoid, assess, reduce, and review. That can help us quite a lot. So even before starting the task, you have to ask yourself, is there a need of doing that? And second thing, you have to see whether, if just example, if there's a big delivery coming, so you have to see which is the right place for that to go, instead of somebody is lifting it and taking it over. So there's a proper risk assessment before starting the task that can help to avoid the task. If that was not possible, if you have to do, then your responsibility to assess the load, assess the manual handling properly, and just to get right number of people and do it safely. So when it is coming to the reduce, so what all we develop, we are putting it together and we are doing it safely. By the end of each action, we have to make sure we have to review the action and make sure if there is anything we can change, and in the future we can try to avoid extra manual handling. Okay, so in this slide, we're just explaining the definition of manual handling. That is from the manual handling operation regulation I already mentioned. So any transporting or supporting of a load by hand or by bodily force. So it's clearly saying actually any activities coming from our body is manual handling. That can be lifting, that can be lowering and supporting, carrying, pushing and pulling. I just added few pictures just to explain a little bit more about that, because some days we might be thinking we are doing only manual handling at work. Actually, no. We are doing manual handling all 24 hours whenever we are doing any task. So you can see a really funny picture on the side. That lady is carrying a load. So it is possible. We all do that in our life. We have to think what is wrong with that. So we just like that heavy load is giving, that is impacting on her posture. So we have to think, how can we change it? How can we minimize it? Then automatically we can take a second bag with us, or even just divide the load and put in a backpack, or just her posture, she can improve a little bit more. So this sort of way, considering the load and posture and try to amend it myself. And when it is coming to the patient, sometimes your patient just they can walk. Sometimes we feel they may need some support, but all the time you have to think about when you are supporting, that is a manual handling, and you have to think, how can I do it safely? Okay, as I promised, I'm coming back to the another slide, that is the training one, that is just regarding what we are doing in our trust. So we are providing the trainers for training for all the staffs in our trust. That can be any job. All the staff joining in the trust, they should be attending the clinical induction. So that can be clinical or non-clinical induction. So non-clinical induction, that is for admin or even not patient-facing staff members. And clinical induction, that is for who all are working with the patients. So the clinical induction, that is, they have to attend the induction in the first week of their joining in the trust, and most of the time. And the clinical and non-clinical update, that is for the existing staff members. The clinical and non-clinical update, they might be having lots of experience where they are working, what sort of manual handling they are doing. So we are giving the opportunity for the staff to decide which is the right program for them. So we have two programs. One is a minimal handling program, one is a full patient handling program. So the full patient handling program, they have to do the e-learning module, then self-assessment questions to confirm they are doing the right program, then attending nearly 2 hours training in our training room. Then the quality training that we arrange with the ward managers, and we deliver the training in each area. And the false equipment training, just to be management of falls, we have few equipments. We will explain that later. So in that equipment, all staff should be trained, or they should be aware how to use it. So we conduct the training, sometimes in our training room, sometimes we visit the ward and we deliver the training there. Okay, so the manual handling team advisory role. So we are doing this sort of 50% of our time. So just to help the service and just to make it better. So main areas we cover, because we normally get called from the ward and ask for help. So mainly for complex patient service. So that is the many patients who is quite sort of difficult and even sort of difficult to like manual handling. Then they have a service line, they can contact us or even they can email us. and we go there and try to help them to find the right equipment. Sometimes we just show them the right practice and we join with the team. Then manual handling ring practitioners or risk assessment. So sometimes because we are working Monday to Friday and the weekend, and even we have to think about all 24 hours. Each area, they have a link practitioner. Mainly the managers are managers and staff members, they are joining together and they're deciding one person from each unit as a link practitioner to help manual handling team. So we can contact them. Sometimes they deliver little training in their ward, and even there's really clear picture, clear information, and even they help the ward managers to do the risk assessment as well. And they get really good training. They have to attend 2 days course to be as a link practitioner, and we arrange meetings and we meet them in the workplace as well. And as an advisory role, we help staff members or even ward to find the right equipment for manual handling. Sometimes we have to think about staff safety and even patient safety, as we mentioned. So some ward, like example, if patients can be in the stroke unit and the cardiac unit, so 2 different types of patients coming there. But sometimes we are expecting a cardiac patient can develop some sort of stroke. So then they might be a little bit struggling. They may be thinking like, oh, how can I manage that situation? And I have to think about the patient's cardiac side and even about the stroke and mobility. Then they normally contact us. We go and visit the patient there and we find better equipment. We contact the different companies and even we have quite good close link between the other companies and we find them the right things. Most of the time, I have to say. Manual handling related DATEX incident and return to work assessment. The DATEX incident, that's the link we are using in our trust for helping or even people to report the injury or near miss. So sometimes people like they have to report it because we are encouraging the staff members to report the incidents. If sometimes they may be helping a patient and even sometimes they felt one of the person is injured or they had some pain. So that is, if they are reporting that, that can help the other people to take extra precaution. We just have a very good link between the management system and we report, we contact them and find out what was going wrong and return to work assessment. Sometimes the people, staff members might be off sick because of the manual handling incident happened in their work. And once they're coming back, managers normally inform us. Then we go and see them on their first day or the first week of back to work. And we spend some time with them and make sure they are following the same system of work and even just to support them. Even that work assessment is quite helpful for staff members because they can say, if somebody was injured and when they're coming back, we are not expecting they should be exactly same as before. They may require a little bit more rest. So this return to work assessment, we can say, yeah, this person is not able to do this task for a few weeks. So the managers will try to accommodate that most of the time. And I just want to talk a little bit about physio direct and occupational health. The physio direct, that is the one physio department, they're helping the staff members. If somebody is injured or even might be work related or they are developing some sort of musculoskeletal incidents or injury, so they have a quite good link with the physio team. They can refer themselves or their managers and they try to see them in the physio department and they provide help and even just to give right exercise or even help them to go in the right path. And occupational health, that is the another body to help the staff members. Even sometimes I said just as a support, they help them as identify if there is any sort of requirement the staff members have, they accommodate that. Health promotion activities along with well-being team. We have really good well-being team in our trust. They just to help the staff members, they arrange sometimes the exercise sections and they just to provide lots of information where they can get help for the staff members. Even in our country, there is lot of especially for NHS staff with this COVID situation. We had lots of help from other like yoga or even any other well-being team. So this well-being team, they just to get the information and they share with all the staff members, so we won't miss anything. Okay, we are just coming to the slide as manual handling risk assessment. It is actually quite important though. So we are encouraging, or even the legislation clearly encouraging staff members or even all of us to do the risk assessment. So before starting, I have to explain what is risk assessment actually. Risk assessment is, we are just easy term, we are assessing the risk. So when it is coming, that can be two different styles. Some of the risk assessment, we are not documenting it all the time. Just for example, like if you decided to sit in a chair, so the chair can be different. Some of the chair can be computer chair with 5 casters on. So another chair is just nice table based one. So you have to see, when you're sitting in both of the chair, you will think, oh, is it safe or do I need to hold it when I'm sitting? So automatically you are doing a risk assessment there to make sure you are safe. So that sort of risk assessment we are doing is called as dynamic risk assessment on the spot and can be undertaken by any individual prior to commencing a manual handling task. So that's the one very important in our life. Before doing any task, ask yourself, is it safe for me to do that? But we are not documenting it. We are changing our practice. But when it is coming to the formal risk assessment, that's a documented undertaking by individual with suitable training and responsibility. So that can be in our hospitals, we have a mobility assessment form. So that is part of the core screening form. We have falls form, we have infection control, tissue viability. So that form, that mobility assessment form, the staff members have to fill it, and that is staying there in the patient's folder and they have to review it. So I will be showing that form later. So that form is a formal risk assessment. So then other things, if somebody is one of the staff member is pregnant and when she joins back, she may need to get some sort of extra help or she may need some sort of attention. So in that situation, anyway, within 3 months of where she is reporting she is pregnant, the managers normally sit with her and see whether she need any help, if she can do everything, and they document it. Even that called as formal risk assessment. So the dynamic one, and when we are doing the risk assessment, we normally use the tool as Stylio. The T stands for task, I for individual, and L for load, E for environment, and O for other. And the T, this means considering the manual handling activity by itself. So we have to think about when we are considering one of the tasks, one of the manual handling activity, we have to think about what activity am I doing? Whether am I doing the right practice or wrong practice? Is it safe system of work followed? Think about twisting, stooping, excessive lifting, lowering and pushing, pulling, holding away from the body, prolonged physical effort, sufficient recovery period, rate of work, handling while seated, and teamwork. So when we are thinking about the task, we need to ask ourselves some questions. Am I doing any of this? So if it is, we have to ask, can I change it or can I reduce it? Sometimes with extra staff member or just to adopting a different practice, we can change our task and we have to adopt the right way. When it's coming as individual, this means considering the person who will be carrying out the manual handling activity. So that might be you or your colleague. For example, how strong, fit or able to do the task. So sometimes I've already mentioned the example, somebody is coming after off sick for a month. So when they're coming back, they might be feeling all right to do the task, but they may need a little bit more extra help. So in that situation, if you are one of their colleagues, always ask for, like always better to ask them, do you need any help? Can you do that? So that may make them feel better. That may make them feel inclusive. And the clothing and footwear and the capability, men, women, age, fitness, knowledge, training, pregnancy, and health. And when we're talking about the knowledge and training, sometimes if one of the equipment, if you don't know, but if you're trying to push yourself to use it, then you're putting yourself in a pressure. So that is not safe. Always make sure you should have the proper training before using equipment. And coming to the load, this means considering the object or person that is being moved and looking at how this may affect health and safety. For example, is load is particularly heavy or hard to grab. And you can think about any sharp surface or even any soil or even what is inside that. Sometimes the way you are lifting can change it if you know what is inside. The working environment, so this can change because the task, if you're doing in a really good clean area, or even if you're performing task in one of the patient's bedside, lots bed and with leg drawers, everything there. So these two can be very different. So always we have to think about the floor level, surface, and working temperature, and even any obstructions or doors, etc. Okay, this that is there with our trust one. So we are encouraging the people to follow the local system. Sometimes even the legislation is clearly saying, like our policy is saying, oh yeah, we need to use 3 people for doing the task. Sometimes in our trust, because of the environment or even thing, if we recognize if they need 1 extra staff, then we just to encourage people to do that, to help them. So that's one called local system. And even each unit, they have their own risk assessment, and even they need to follow that. Okay, as I promised, I'm just showing you the mobility assessment documentation. Okay, so this is one of the formal risk assessment we are encouraging the staff members to perform in our trust. I know it is not very clear for you to see, but I can just to go through that. There is two paperwork there, 2 sheets there. The first one is the patient risk assessment. So that one, more mobility assessment form. So we just do that within 6 hours of the hospital admission. We encourage staff. Sorry.
Jasmin, can you come out of the full screen and just enlarge that bit? Come out of the presentation mode.
Okay.
And then just enlarge that bit again. Just start sharing again.
Okay.
Perfect. Just enlarge the screen if you can at the bottom. Right.
Where is 38%? Yeah.
Yeah. Keep going. Enlarge it on the. Yeah. Now you drag the form to the middle.
Here.
On the top with the cursor. Can you see it? Still not visible.
It's not clear.
We still can't see it. It's a bit better if you go by one, enlarge it and go one by one and just scroll it down as you go along.
Okay. So this one, I'm sorry, the screen which you're seeing is that is a mobility assessment form. That's one we are encouraging the staff members to do within 6 hours of hospitalization. So once they are admitting, sometimes the patient's mobility can be very good, but if they came and went for a surgery, the mobility can change. So we just need to make sure we are aware what we are expecting after the rehabilitation or once they're feeling better. So this mobility one, which so the first one, like how like independent and even what sort of age and the patient's body weight, and do have any attachments. Sometimes patient has walking aid, syringe drivers, sedation. So as per this, the staff members have to score it properly. And under this, you can see there's a three color that's color coded. The green one is 0 to 6. That's a low risk, and 7 to 16 is a moderate risk. 17 to 20 plus. So that's a high risk. So once we are asking the staff members to add all the scores together, and if it is coming 0 to 6, that might be like one of us, very independent, and they might be not required lots of manual handling help. And 7 to 16, we are expecting they need some help. Okay, they might be using a wheelchair only for like mobility, but they may be okay to stand up, or even they may need one equipment just to help them. So that sort of patients we are calling as like moderate risk patients. And we have to go to high risk. So that is the category we are expecting most of the patients may require lots of manual handling. So this screening tool is helping the staff members to identify. And 17, 20, 20 plus, that patients might be bedridden and might be have lots of tubes and lines, and even their mobility is really restricted. So the people in first group, second group, moderate, and even the high risk, we are encouraging the staff members to refer the patients to us. So that, and even there is a complete mobility care plan. That's what I was showing next. So I can.
Do you want me to share my screen? Or can you see it? Okay.
I think okay. I think okay. Isn't coming now, isn't it? Yeah. So that one, the second one is mobility care plan. So that one, we are encouraging people in the second and third group. They should fill that, and that is available for the other staff members. That's very helpful though, because sometimes the shift change, then the staff members coming in the next one, they know what sort of techniques is better for that patient and how many people were available. And sometimes this can be legal documents. If something went wrong, then they know whether they followed the safe system, whether they know whether they followed the right things. So is it clear or is it okay? Yeah.
No,
and even in that one, we are identifying what sort of measures, what sort of technique we need to use, like chair transfer, and when patient is getting up from the bed, or even just to toiletring, and even so that sort of way. So any of that one, we are identifying what equipment they use and how many staff members were there and what sort of technique they use. So sometimes we encourage the staff members just to write it properly. Like sometimes when I came today, only 2 of us helped a patient to move. But later in the evening, patient may feel a bit more tired and you may require 3 people. So we encourage the staff members to write us 3, because we need to see the maximum numbers there. So that can give the right information for the next team group. So we don't want, we just try our level best to encourage the staff member to follow that. Okay. So now can I share that, Tipe?
Yes, please. Yeah. Go on to the presentation mode. Yeah.
Okay. The previous screen, we just mentioned about the complex patient little bit. You know that patients, I said, who is scoring high, like 17 plus, we call them as complex patients. So that can be because of their illness. The patient whose body size or shape and medical condition create moving and handling challenge. So that is to help the patient and to help the staff members actually. So that can be because of plus size or even the cognitive impairment and even with the health conditions. So in these patients, we are encouraging the staff members to contact us. So we sometimes we talk through and we can help them. Sometimes we visit them. I visit the ward and we arrange it and we document it properly in their note. And now we are trying to make it as electronically. So that means if the patient, because few occasions we realize when the patient is readmitting, people are contacting us back again because and few hours there was a lacking. So now we realize electronically if they're recording, once they're readmission, they can get the information again. So we are working on that to make it better. Okay, that's plus size patient or bariatric patients. So it is we get like plus size, like according to the Bristol Weston, like years ago we identified sort of patients over 159 kilo we call as bariatric. But actually that is not according to the weight. Sometimes not only the weight and how the body weight distribution. Sometimes patient can be 159 kilo, they're quite tall, they're running around without any problem. We won't notice it. But sometimes patient might be 130 kilo, they're sort of bedridden, or even they're amputee. So then that can be manual handling challenge. So we just call this, or we identify bariatric according to the patient's body weight and how the body weight distribution. I just added few pictures to that slide. One is that is sort of a, when we are considering bariatric, we can say pear shape or apple shape. So even that matter when we are caring for the patient, we should keep the patients a holistic being and we support them as much as we can. So we have exactly the right equipment available to help them. So we have bariatric beds, we have bariatric commode chair, we have bariatric chair. Sometimes even the new building, we have a room a bit more bigger. That means we have facility to store all that things. And once the in-house facility is not available, we have quite close link between other companies. They deliver it within 4 hours of their admission. So when the patient is admitting to the A&E, we normally get the information where the patient is going. In the A&E, I mean the accident emergency department. So the emergency department, they use the trolleys for the patient, but even the bigger size there. And once the patient is admitting there, the patient is going to another ward, but they don't want to get a delay, but we want to respect our patient. So we inform the ward where the patient is going, and we most of the time we arrange all the equipment before the patient is there. Then we go and visit the patient again to make sure everything is coming up properly. And because of the COVID situation, there was a delay. We were not able to go everywhere, but still the staff members, they contact us, we provide the information to them. Okay, we have a very close link between the dementia and delirium and falls team in our trust. They're a very active team and they go around and see the patient all the time. And always we encourage falls prevention. So complete the relevant care plan and risk assessment. And sometimes we do the audit to make sure are they following the right thing. I know extremely busy one, sometimes they delay, but most of the time they try to do that. And encourage the patient to wear their own footwear. And the dementia and delirium falls team, they use all about me form. So that is actually a booklet. So when the patients are coming with confusion like dementia or delirium, if it is identified or even they're identifying in this admission, this ward staff, they have to provide all about me. That is the form to the patient or to the patient's family member once they come. Just for example, I like to call, I'm Jasmin, but I might be called with some other name. So when I'm admitting to this admission, if somebody has a confusion, they prefer to call the name they used to be called. So if that all about me form, they have opportunity to write down what they like and what is their priorities are. The staff members, most of the time, they try to follow that. And even the dementia team, they have helpline, they have briefs, they contact them as well. And even we have quite closely, if they found any manual handling need, they contact us too. Now we are coming to the management of falling person. So I already mentioned about the mobility assessment form. It is must, and that is staying with the patient folder. In case if they're transferring to the another ward or patient is going for CT scan or any X-rays, we are encouraging staff members to send their mobility assessment form with the patient. So in case if patient's condition change over there, the people there, they can expect and they can do the same thing. And real-time decision-making process. So we are not like encouraging people to catch someone when they're falling, but still real-time decision-making process. Sometimes if, for example, if I'm running from here to catch someone who's a little bit far away, it's not going to work, and even I definitely get hurt. So we are encouraging people to do the risk assessment and see whether that is safe. Can I perform that safely? Okay, and even somebody is like another example. If somebody is 6 foot, 5 foot, and helping a person with patient with 6'2", and you know that it is not going to help. So it is not going to be safe for them to hold it. So in that situation, we are encouraging they should not catch. And don't attempt to lift from a floor, ensure a protective environment and obtain help and use the right equipment. So in case if patient had a fall, we should not rush and lift someone from the floor. We always say, yeah, the emergencies, we have to call the emergency. Most emergency, we can treat in the floor. And once they're feeling better, we can get them back with the right equipment and just right number of people. Our trust, we have some false equipments we use. In this picture, that first blue one looks like the air mattress. That is one of the fantastic equipment we use in our trust. That's called hover jack or lifting mattress, like air patient lift. So this can take quite a lot of weight actually, but the size that looks like a mattress actually. But you can see that is already inflated. So when patient had a fall, especially bariatric patient, we are encouraging people to use this because we can just to turn the patient very little bit and put it under the patient and inflame it, and that should be like a mattress, like a 4-tier mattress. So from that, we can slide the patient, we can move the patient to one room to other room, or even we can slide from bed to another bed or trolley. So the second equipment, you can see that yellow color board that we called as scoop. That's from the Furno company which we are buying. So that can take 227 kilo, but not looks too wide, but that is quite good to support the patient with spinal injury. So when people in the floor, that is available in most of the wards. The hover jack, we have only 2 in our trust, but that is enough because people can get it. One of the room we are keeping it, and the scoop is available for every one or other ward they can use it. And that equipment, saying the patient with when somebody had a fall, we are expecting sort of injuries like head injury, spinal injury, hip fracture. So any of these sort of situation, we are encouraging people don't move them without the right equipment, and we just do only 10-degree turn and just to insert furnace scope, and we encourage to do the risk assessment again. And if the risk patient is sort of lightweight, then minimum 6 people we are asking them to lift the patient up. And there is straps along with the phernoscope. Always we should use only this strap because the patient should be safe and the staff member should be safe. And you can see one more equipment called Hoist in the end. That equipment we can use in conjunction with phernoscope to lift a patient up. So that's the way, if these 2 equipments are there, no need of lifting. You can connect the scope and can use with the hoist, or connect the scope and you can use hover jack under the scope. So these 2 situations, we can try to avoid lifting that way. But if there is no scope, no hoist or hover jack available, then we have to lift it, but minimum 6 people. Okay, we just mentioned quite a lot about back problems and even how the spine, what is the importance of we need to follow the right manual handling. So it is actually our spine. We have later next screen we are going to show you spine video. Then you will realize it. You all might be aware about it. So most of the time, musculoskeletal injuries and even the poor manual handling can injure your spine. So you can see that in this picture, the normal disc, our normal disc should be look like the top one. And once we, most of the time, as a working people, like most of the time, with little ache and pain, we ignore. And we just keep going with that. And in that situation, we are not thinking about our spine. And we might be developing the stage as degenerative disc. Okay. Then once the degenerative disc, if you are not giving enough importance, and that can end up in bulging the disc, and that can lead to herniated disc, and by the end you will be end up with thinning the disc and even a really bad disc prolapse. So what I want to say from this slide is always we should try to keep it as normal disc, and even if you are getting any pain or even any sign of degeneration, we should give extra precaution and we should look after. Our spine is very important. That is only one spine we have. Okay, just could you please play the spine video for us?
Sorry, do you want to play the video?
Yeah, yes, please. Can I
Suresh, are you okay to
stop
play?
sharing mine?
Okay, I will. Yeah, you have to.
Yes, please.
Thank you, Ramesh.
The lumbar region of the spine, more commonly known as the lower back, consists of 5 vertebrae labeled L1 through L5. The lumbar region is situated between the thoracic or chest region of the spine and the sacrum. The lumbar spine typically has a slight inward curve known as lordosis. The lower back region contains large muscles that support the back and allow for movement in the trunk of the body. These muscles can spasm or become strained, which is a common cause of lower back pain. The 5 vertebrae of the lumbar spine are connected in the back by facet joints, which allow for forward and backward extension, as well as twisting movements. The 2 lowest segments in the lumbar spine, L4, L5, and L5, S1, carry the most weight and have the most movement, making the area prone to injury. In between vertebrae are spinal discs, which cushion the joints of the spine and provide support. Discs in the lumbar region of the spine are most likely to herniate or degenerate, which can cause pain in the lower back or radiating pain to the legs and feet. The spinal cord travels from the base of the skull to the joint at T12L1, where the thoracic spine meets the lumbar spine. At this segment, nerve roots branch out from the spinal cord, running from the lower back through the back of the leg and down to the toes. Some lower back conditions may compress these nerve roots, resulting in pain that radiates to the lower extremities, known as radiculopathy.
Thanks, Suresh.
Okay. Do you want me to play another video?
Yeah, I'll share. Sorry. Okay, thanks, Suresh. So in that clearly saying what is the importance of looking after spine and even just to try to avoid the repetitive injury and workstation assessment. That's the next screen I just want to talk through. The workstation, it is now the technology has gone up a lot and people are in work related and even in our day-to-day life, we are just depending, we are using the computer screen or even mobile devices. So we mentioned, I think the HSE, the Health and Safety Executive, in that screen, we already said how much injuries happening with the neck and even the lower back. Most of the time, our wrong posture is creating that And even you can clearly see that in the first picture, it is saying what sort of posture we should adopt when you're using a computer screen. And we are expecting people should be sitting in sort of right, like 90-degree angle, and even just support what sort of strain that can cause. So first thing is the stress level is going up, and even our eye strain and neck and lower back, and even all our other part of the leg body. So you have to see, set your chair and just like this, and even that can be better. And the next thing is here, which we are seeing, this gadget on a trolley we called as. So we are using electronic paperwork, and even the staff members, they're using the laptop. And this is the basic version. We have few different versions there. And according to the people, like somebody's really told this is going to be really low, so they have to do the risk assessment, then they will arrange for a different option. And we encourage people like who is working with the computer desk more than an hour, we called as DSC users or display screen equipment users. So for that people, we are encouraging to go to our manual handling folder, like health and safety website, and even do a workstation assessment or cardiness assessment. So that will help the staff members to identify the risk is involved with their workplace, and even they can change themselves. In case if they need some sort of help, manual handling team or occupational health team, we visit their workspace, and even or even sometimes we ask them to come to our side, and we show them and go through what is right and what sort of changes they can adopt. And ergonomic products are available. We have some of them we can give for trial. Some of them we have really good relations with different companies, and they can purchase it, and or even someday they can trial it from them as well. And ergonomic chair, people who is working for long hours, ergonomic chair and even ergonomic equipments are something very important to help them. And we always encourage people to get up from the screen every hourly, nearly 50 minutes, 50. We are encouraging them to at least stand up and do some stretching. The posture principles and sustain awkward posture, like especially when we are considering about like the job we are doing in our clinical area, in changing the linen, supporting for the procedures. Most of the time when we are considering somebody is doing a procedure, we give importance for, and the people who is supporting, they might be having a really awkward, fixed or constrained body positions. So we always say just to think about before starting the task, think about the team members and working together, and just to create or find a better posture, sorry. And sustaining force, pushing or pulling equipment. And you always, before you starting the task, ask yourself, do I need to do it? Do I have to open a door, or even just is it the right way I need to do? And just to follow, just to keep our body posture properly. And frequency and repetition of movement and additional factors, stress, time pressures, underlying health condition, equipment, and environment. The principles of handling. So this is the posture we are asking people to adopt. So that is from the manual handling folder, manual handling regulation. So principles of handling. So just before starting to do a task, think and even stand close to the Lord. And always you can see in that picture that people, they are performing a tug of war. So that's the one of the best posture we can adopt for our manual handling task. Always wide apart and keep Lord close to the body, and look forward and use the body weight to lift or move. And when you're working as a team, always think one person as a team leader and to coordinate with that person. Yeah, this is from the health and safety executives. That is from the HSC guidelines for like lifting. But I can clearly say, even that is saying men and female, that sort of weight limit people can lift. But actually, this all according to how the patient's abilities. Somebody had previous injuries, or somebody is not able to do that. That's absolutely fine. We have to decide how much we can do. But this is just a guideline. But we can just always say like, oh yeah, you are a man, you have to lift 10 kilo. No, it is nothing like that. Okay, just for helping us, for just to supporting manual handling team, and we have manual handling equipments available in your trust from slide sheet and from with hoist. We have loads several equipment we use to support the patients. So now. So some of the equipments for people with really good upper body strength. So that equipments we help them to mobilize them and even just to keep their mobility and keep their independence. But some of the equipment like a hoist, that is we get it from different companies, and even that is for patients who is sort of bedridden. Sometimes because of health condition, we need to mobilize them, and even if clinically if they're okay to mobilize, we use a equipment called hoist. I have a video to show you that is from the YouTube video. That is one of the same company we have the hoist from. That is from the Lico company. And if or Suresh, do you mind to please play the hoist video for me?
Yes, sure. If you exit from the slides,
I want to exit from my screen. Yeah,
please.
thank you. Thanks, Suresh.
Yeah.
Sorry. Okay, so just that video was showing how the hoist work. Hoist is one of our best manual handling aid for helping the people who is bedridden or he or she need lots of manual handling help. So we have different types of hoist available. Some of them ceiling hoist for one bay or even one of the bed space, and even we have mobile hoist. That's when you were just watching. So this is very useful for people just to encourage them. Sometimes otherwise, like we have to use our manpower, but it is a great help for staff members, and even we can keep our patients' dignity and encourage their mobility as well. And this next one I'm going to show you, this is Handicare Return 7500. We have two models available. This is a normal one, and even one is bariatric version. So this is for encouraging. I can show you the picture how that works. And even before the equipments I'm going to show you now, that is for good patients with good upper body strength. What I mean is, some of them, they have some ability to push and stand up, but they are not able to do it by themselves. So in that case, we encourage staff members to use the equipment than doing the manual lifting. So we have equipment that always we are saying two staff should be available and supporting when we are using one of these equipment. That is for the safety. And my colleagues, we just took some photos just to show you how to use that equipment. So we can get the patient from chair to bed or bed to chair or chair to wheelchair or commode. So we have to get the equipment close to them, and we are encouraging the staff patient is holding on that and using their body weight like just standing up. Then the staff members who is helping, supporting, they have to follow the principles of handling. That means you can see the tug of war stand in that. So if somebody is using this, let's say we can try to avoid the risk. We can try to reduce the risk. And next one is Arjo Steady. This is another equipment, very useful equipment. Even they have two different models. One is Arjo Steady and one is Sara Steady. This can take 120 kilo, and the bigger version can take 175 kilo, and the wheels are very good, and we can wheel it around to the toilet that can meet the toilet needs. And this is going to be like this, from bed to chair, chair to toilet, little movements we can do. But any equipment before using, proper risk assessment is important, and even we always make sure they're okay, and even that is for encouraging their mobility. And this is another equipment, Arjo Engo Standing Hoist. This mainly using the places like stroke rehab or even in a rehab ward for supporting the patient with rehabilitation. So when we are using this, this electric one, and this you can see that battery there on the side, and we can change the battery, and even we just to, we use a strap along with this, and we attach the strap, and we can use the remote to lift the patient up. That means even little bit more less than Sara Steady, this patient, that sort of patients, we are expecting to use this equipment. And physiotherapy staff available in each ward, therapists, so they can help as well. They are well trained for this. I just have another slide to show you some of the other manual handling aids. Slide sheets. That red sheet sitting there, that's a slide sheet. We encourage staff members to use that wherever they need it. So that can be one of the cheapest and best manual handling equipment. That is available in 3 different sizes. One is normal size for patient with staying in a normal hospital bed, and some of patients can be a little bit more bigger. We have a bit more bigger version called pediatric, and big version, double size like a bariatric version. So we encourage staff members to use the right size to support your patient and even the staff member. And always we have electric beds in the hospital, so we encourage to use the electric function. And even the board, I'm just put it there, that is a patch slide. So if your patient need to be transferred from one surface to other surface, we encourage staff members to use slide sheet and patch slide. Or we have another device called AirPal or JC100. But these equipments, we can do it together. That can reduce the risk, and minimum 4 people should be there when you're transferring someone from one bed to another bed. Okay, top tips to reduce the risk of injury. I would say always keep active, and even after a long shift, once we are going home, always think about your health and just think about what am I going to do. And even this is 24-hour care, not only when you're at work, but even when you're at home. Always we have responsibility towards us, and we have to look after us. And even make sure enough breaks. Take your lunch break away from work area. Sometimes we feel, oh, I just can't bother to go out. We have to change that practice. Think about the fresh air and change your posture regularly and seek support when it is required. Even if you're feeling a very mild pain, better to treat that second than waiting to get it as bad. So most of the time, and the communication, that is very important. If you are not well, talk to someone. If you need help, ask someone and work as a team. That is something very important. This exercise is what supposed to be, we should add, because we all do some exercise, but always better to concentrate a little bit on abdominal strengthening exercise or core strengthening exercise. If you have really good strong abdominal muscle, it's very less chance for you to get lower back injury. So always try to practice something which is available, which is easy to access. And even the Pilates and yoga, some of the example we given, not only that, you can adopt which is right for you, and even you can be happy. Thank you. I'm sorry, I just rushed a little bit in the end, but I think I took extra minutes. Sorry about that.
Thank you so much, Jasmin. That was brilliant presentation. Thank you for showing the aids that are available out there in the market. And I think there's lots of YouTube videos are available for you guys to watch it for moving and handling equipments and how to use them. So please do make sure you browse them and look at them and see whether you can implement them at your practice. I'm aware of the time. If you have any questions for Jasmin, please do either type in the chat box or you can unmute yourself and talk.
Okay, Naresh is having 3 questions.
Okay, fire away, Naresh.
First question is, some clinical nurses are facing spine problems due to poor patient manual handling. So please share these simple tips for the staff nurses.
So the spine problem, if they're already facing, always I would say talk to their manager, and they should control and they should reduce their activity. They should give some rest for some time, and even just to do what they can do. And even always better to get some sort of helpline, and just to get some physios involved, and even just to make sure do the right test, right, like sort of CT scan or MRI to make sure what is wrong before they are introducing something. And very little, like slight exercises, the posture awareness and mild exercises that can help. But if some people are already facing problem, I would say better to get some sort of physio input or even some sort of scan or something to make sure they are not putting any extra pressure on that to make it worse to start with. So once they are, then they can introduce some exercise sessions.
Jasmin,
Is it clear?
Just adding to that, Jasmin, thank you so much. That was brilliant. So like Jasmin said, do what you can. So do within your limit, do whatever activities you can within your limit, like she mentioned in the presentation. That's the first thing. And use the available equipment that are that you can use as an alternative. and make sure you're trained well and your employer is aware of this equipment. You can introduce them. The other thing that you need to know is 40%, despite of using all these equipments, 40% of the sickness within the NHS is due to back injuries every year. So that's how much serious it is. So you got to be careful about what you do, the activities. So for example, if someone has got a spinal injuries or spinal problem, chronic spinal problems, if you are unable to fulfill a task at certain workplace, then you got to think about moving to another area where it is safer for you to practice. So redeploying yourself to another area is another thing that your employer has to honor that as part of your contract. Yeah.
And even the physio direct help and even the occupational health, they are the team to help the staff members. If they think like, oh yeah, that as Pratip said, if the work atmosphere is creating the problem, they can talk to them, they can refer themselves, and even they have to make a plan what they can do. And even at least sometimes that might be for only few months. Then they can come back to their area, or even they feel like, oh, it is really helping, it is really affecting. They have to think about the change the like to different area completely. So it can be, and even once they're feeling better, always move around and do some exercise.
By remaining in your work area, you are putting other patients at risk as well as your colleagues at risk, because of your back injuries, you're encouraging your colleagues to, you're not encouraging, you're forcing your colleagues to do your task, which is not fair. And also if you try to do it yourself, you're hurting more, you're causing more damage to yourself as well as to the patients as well. So you got to really think about it. Okay, next question, Rajendra.
Next question is how to handle the head injury patients in spite of hand wrist also controls the patient. I'm not sure about what exactly it means, but I presume that how to handle the head injury patients, I think.
Okay, 1 second.
And if Naresh, if you're available there, you can unmute yourself and you can ask the questions directly.
Jasmin, could you able to exit the screen, the side screen, please?
Naresh can ask you a question directly. Yeah.
Okay.
Yeah.
So how to handle the head injury patients? He was very irritable. Instead of hand restrainer, also patient is, we can't control the patient.
Jasmin,
okay.
Can you stop sharing the screen?
Okay. So sorry.
Sure. Okay, thank you.
Yeah.
Okay, go on, Jasmin.
Yeah. Okay, you can start. Yeah.
No, go on.
The head injury patients normally, like we have facilities. We are not restraining them completely, and we get right number of staff members on board, and we have to support their neck and head.
Netravati, can you unmute? Sir, mute your. That's right. Okay.
We have to support their head and neck. That's from A&E itself. They do the head like head support, and from there itself they are doing that. And even as I said, if they need sort of spinal support as well, even not for MRI scan, other things, we are encouraging people to keep that scoop board underneath. That means that will make them to stay stable. And even there is straps attached to that. So that yellow board which I was showing before. So when patients are on that, they are quite sort of nice and stable, and even that is much easy and safe for staff to handle. And in that situation, that is not happening all the time. So more people should be available to do the task. And always the risk assessment based approach, somebody is not very well, so they should try to be like minimizing the risk, and they should be in the lower part than they should be in the somewhere need more sort of manual handling. And in our hospital, we have clinical holding sections are there. So they are helping. They're teaching the staff members how to support when patients are confused or they are they need some sort of support in that situation. So they teach quite sort of good way to handle. So even they are sort of manual handling, they're applying in that and make sure staff safe and patient safe.
Thank you, Jasmin. The other things that you can consider using is the head blocks as well on each side. If you Google head blocks and to restrain the patient on the position, you can put the patient on the scoop and protect the side, put the head block on each side and strap it. So that's other way of restraining patients with head injuries for any investigations, because you know that you cannot sedate those patients. So it's a difficult task. And then they probably need one-to-one nursing. If needed to protect the airway, if you were to sedate those patients, you may need to consider HDU admissions or intensive care admissions for those patients. Yeah, thank you.
Okay. Can I have a question? Do you have time?
Yes, yes, yes.
Thank you.
The problem is, we don't have occupational health facility here. Anyway, if something happens to staff, they have to go to OPDs and they don't get a leave for the injury what happened during workplace, during work time. That is another problem. But I know it's not like a UK. We can't expect all those things here. Even equipment, leave wise, even staffing ratio, everything we can't expect. But the thing is, at least there is no staff to replace. If something, Naresh is working in a neurosurgery ward, for example, if something happens to you, to him, so there must be another staff to replace him, isn't it? And it's so difficult in our situation. And you are saying that for your problem, you are troubling your colleague to take more work. That is also that happens here. If someone is not well on the board, one person has to do two people's work. They have to handle 4 patients, 8 patients, ventilated patients, irritable patients, like this. I don't know how to correct these systems.
So there is a systemic, the only thing you can do, that's what Jasmin was mentioning about incident reporting, DATEX reporting. So you got to make sure if you are short of staff, if you're unable to fulfill the task.
Incidents report we write, but who is going to see those? Who is going to solve those? There is no incidents report. Incidents reports nurses can write, but who is going to read those incidents reports? Right. And who is going to solve those? That I don't know. This a whole system is like that.
I think the system should change actually, because years are going. We all are human beings, and even we are treating our patients, and our health is something important. So I think only through our associations, nursing associations, we have to bring it up, and even we have to see how we can establish. Because if one country they can do it, so they should at least start to go that right way, and otherwise there is no way, because they have to understand. They have to compare how other countries are managing and how they're getting the staff, how they're looking after. I have to proud to say I'm working in the same trust from 2003, and I feel like whenever I was in a need, they were there for me. But I'm not saying like these things not happening in one day, but they have to gradually progress it, and they have to think about it a little bit. I think we should be open. We should try to address our issues. We should try to go through our associations, and even that sort of way we can establish a little bit more better. Like as you recognize now, the system is not there, and that means you are so good in your mind. So this sort of way we need lots of people in India to address it and to think how can we establish it, and how can we can provide some more cheaper equipment to start with. No need of very expensive one to start with. Give some small equipment and give to see like more training, and encourage the staff members to do that to start with. Then you will be able to see a big difference, and you will be seeing like your staff members, how happy they are and how you're looking after well-being. And then they will be able to establish it in their like bit more.
The sliding sheets and pad slides are quite cheap actually. Sliding sheets probably cost about 1,000 rupees, and a pad slide cost about 3,500 rupees. I remember this in KLE conference when we did it. That's the price of it. I think those things that you can implement, simple things you can buy it. And also I know you mentioned about filling out the incident reports. What actions has been taken about that? Like Jasmin mentioned, those things have to be reviewed. How many do you fill in a day, in a year? See, for example, ours is a very small hospital. I work in a 400-bedded hospital, and there are about 5,700 employees in our trust. and we filled in 7,500 incident reports last year.
Here,
But actually, if we come back to from Saramagal sister point of view, they are facing the practical issues on ground.
I understand, but at the end of the
Okay,
day,
so
we
I
can't.
think best way is that if I was in your place, sister, like what I will do, what are the resources I have? Like for example, as the person mentioned that, okay, these are the cheap resources what available in the market, like pad slides or sliding sheets. I'll make a list of resources, what is available, and I'll openly call the meeting with the staffs. Okay, these are the resources available. How best I can train you in this one, and how best you can use these resources to protect you and protect these patients. So without the involvement of the staff, nothing can be done. And that's a practical problem, what you're facing, totally understandable, and system can't be changed in one day. So if you start with a small thing.
the biggest problem,
Yeah,
so
and even
there is someone, you know the things, you know exactly what you need to do, but I have no one to help, no one to listen to me. What you do, that's the another thing. And the staffs are suffering from, lot of nurses have back pain. It's not
I would say the easy thing you can start, because you have such a good mind and you want to do the things. I would say from my perspective, just to start with some more breaks or little bit exercise in the workplace, because we do that. We are encouraging when people are in static posture. We say like then that is not costing any money at all. Like it was just to make it as a practice. Like lunch break is 1 o'clock. So just say 11 o'clock we have a 5 minutes meeting, and just to try to join us, because 6 of them working together or 4 of them, 2 at a time, just to come and just to, even we can help to find out some nice exercise. So do some stretching exercise, and once they're going back, the next team can do others. So these sort of little things, they can practice it themselves. And even I would say, like just example, I want to use one of our hospital, other NHS trust I visited. They care lots of patients with dementia, and they pilot one ward just to let's start with some different changes, and they have made massive difference. Then they started to change that to the full hospital. So I would say you start this exercise thing and think about the staff well-being little bit. That is not costing any money. Then you can just to find a right person in the trust to just to see, can you just have little money and start some slide sheets. So these sort of introduce little bit, not too much at a time. Then people will start to see a difference, how sickness is reduced in your area, how happy your staff members are. So these things make a big difference, and they will start to think about establishing or even getting that one from you to other places. And even we all are here, we can just support you a little bit with these things, but always start with a little bit.
Naresh, if you're in the group, if you're experiencing day-to-day practice issues, then I encourage all of you to share that in your clinical group, so others can support you.
Thank you. That would be good. And here we don't have, mandatory trainings, induction. If any new staff enters, there is no induction training. In induction, in UK, we have manual handling, one moving. Here, we don't have those facilities. I think, whenever you come to India, think about those trainings, Swami.
Okay.
That would be great help. One
my,
my
bill will increase.
They're not going to pay you any bill, but it is charity work if you want to do.
Yeah, that's good. Nice.
We'll work on it. We'll work on it definitely. Yeah.
Definitely, we need more handling and moving training. Definitely, we need those. And team, a task force team. We have regulations. We don't have those things. If you give those things, it will be great help for and handling for the staffs. We don't have those regulations. I didn't know that. I would have steal from there when I come back, but I didn't think of those things,
Yeah, that's true. I think lots of things can change. I think only because like a baby, when baby is crying, we feed them. When baby is sleeping, we want.
Only pediatric and neonatal. I never thought of adult, but I have to work with the adult people as well after coming here.
Okay.
Thank you,
Oh,
sister. Is anyone else has got any questions?
I
Any
think
other
from
members in the
Naresh
group?
also one more question is there, that is if the patient suddenly irritable, means like I think if the patient suddenly becomes irritable and how to handle if the one staff is available on the floor. I think I don't know from the manual handling perspective or from the management of aggressive patients in the department. So I don't know, it's having two perspectives.
Okay.
Even-
But Naresh, I'll come back to your question. I'm aware of other participants in the group. Can we check if anyone else has got any other questions, please?
Not in the YouTube and not in the what is chat box in the Zoom also.
Yeah.
If somebody want to
So,
ask the question, they can unmute and they can ask questions directly to the speakers.
yeah.
No, okay.
Okay.
Okay. First of all, it was wonderful. Jasmin, thank you very much.
Thank
It
you.
was a wonderful talk and it was so well presented. A very useful, topic, needed topic for our staff. And very nice to see you after so many years, Jasmin.
Thank you so much. It's a privilege for me to come in front of all of you. It is.
Thank you
I always proud to say I'm a Babuji student. I always enjoy the time I was there. If there's a chance, I always come back there. And then one of the place just make me to reach here where I am now. And I'm always happy with that. Thank you so much. Thank you so much for listening me.
Well, we
And thank
still
you,
have to,
Suresh,
we still have to answer. We still have to answer Naresh's question there.
Yeah,
We
the
still
last
haven't
question.
Oh, sorry. Oh, sorry. What was that? Sorry.
So Naresh question is that if the patient become irritable or agitation in the department and if only one staff on the floor, so how to handle it?
Just normally in our trust, as ma'am said, I think our hospital is quite different actually, like our NHS trust. Even we have sort of call bell system there. Even I can say, even there, patient call bell or something you should use, and just to invite more people to arrive to that situation as quick as they can. And always think about even just what I mentioned before about the risk assessment, how safe for you to handle that patient in that situation as without any support for you. Yeah. If you think you can manage it without injuring you badly, then you should encourage you to do that. But if it's a cardiac emergencies, okay, you should put some effort as a nurse or even as a health person. We always can't stand and watch when the patient is getting completely unwell. But if there is a way you can slide them, or even it's a very controlled move and slide them to somewhere safe on the floor or bed, which you can do after the risk assessment. If it is not, I would wait for more people to come. If they're safe on the bed, no need of rushing and doing something. Always ask yourself, is it whether I can avoid it as manual handling regulation? If you think like, no, I can't avoid it, I have to do something very urgently, then I have to think myself, what is safe? So it don't take minutes or hours, will take only seconds. And you just to think, what is safe? Am I, some days, for example, you might be standing upright and helping someone. And if you are in a tug of war position and helping someone, or if you are back of the patient and pushing them. So you ask yourself, which is the right one I can do in that situation? Then you thought like, oh yeah, I can be on the patient's back and I can support them. So always go for the safe way. Yeah. So there will be, when we are doing the activity, sometimes there is sort of mild to moderate risk is involved. But if it is coming as severe, we should try to avoid. And even if you can reduce it a little bit more, you should try to do that. And even always wait for more people to come if there is a possibility. If it is not, always think about your safety as well, and just instead of just rushing. Because from my example, I can say, from my experience, I can say most of the time when we are rushing, most of the time we are getting injured. So think about, can I just to do it in a different way? We are not ignoring the patient. We are looking after them so well, and but safety is important. I would say, yeah, only do what you can. Don't rush and do too much. Is it clear?
Okay. Yeah, it's clear. Thank you.
Thank you.
Thank you, Jasmin.
Thank you so much. So nice to see you, Mom.
Thank you. That's
One
okay.
quick question, one quick tip I'll tell you. If you are really short of staff, and if you're struggling to manage the patients that you have, sometimes you have to think outside the box. If I'm unable to manage the group of patients in my unit, I have 20 patients. I'm the only staff nurse available. You got to escalate it to your supervisor and say either get me staff from other unit or move some of my patients to another unit. So they have the choice. Once you escalate it, you offloaded your responsibility. You cannot keep quiet. You have to make sure you make a note of that, escalate it to your seniors. And it's ultimately it becomes their responsibility as long as you notify them. Thank you.
Yeah.
And even the culture is different, UK and India. Like I think if one person is just coming forward and saying something, sometimes they will just to mark them. But I would say don't go as one person, go as a group. So then that is a good team strength, and even we can just to get better report, better result. I would say just to the team leader as a team of people working together, and they should not change their mind. They should stand for what they want. Then
So that's how you are dealing with a principal in the College of Nursing at Bapuji College, wasn't it, Jasmin?
Yeah, that's true. That's true.
Go as a
coming
group.
back to that time.
Okay. All right. Thank you very much.
Thank
Thank
you.
everyone.
Thank you,
Thank you,
Rajendra.
Suresh,
Thank you, sister.
Rajendra and Tippe for
Thank you.
organizing this. Thank you for inviting me.
Thank you.
Thank you.
Thanks
Thank
to
you,
all.
Jasmin.
And
See
one
you.
more, sister, from our side, if you're looking for the simple tips for the back pain, we'll try to contact the physio departments here and we'll try to share the simple tips for the staffs, how to take care of their back
Please.
injuries or back issues.
Yeah,
Okay.
please.
And any correspondence is there, we'll communicate in the group, sister.
I'll communicate in the group. Okay. Thank
Sister,
you.
one thing before you go,
Yeah.
I can see a few people in the background. How many of you are regularly participating in the daily quiz?
Daily quiz ಮಾಡ್ತಾ ಇಲ್ಲ.
Okay.
ಮಾಡ್ತಾ
Right.
ಇದ್ದೀರಾ?
Right.
Only 3-4 hands I can see.
Okay. So, I mean, you guys ask for these things, practice development. I mean, these things won't happen unless you participate. We make all the efforts. We make all the efforts to improve your practice. And if you yourself don't participate in these things, it's not going to happen, is it?
Yeah. There is Kavita illa ivattu. Let Kavita come because I'm not in the area. Let Kavita come. I'll communicate with Kavita and Dr. Kalapnor as well because
No,
this not
it
go
doesn't
away.
have
It should not come from the
not
management,
come
it
from
should come
anybody.
within
It
them.
should not come from Kavita. It should not come from Kalapasar. It should not come from you. But it should come from them, the staffs themselves. It's
only, I know, but I can see not many people are answering the quiz, not participating that quiz. I can see in the group very
Yeah.
few people are participating.
Yeah.
Because I'm not here, I can't encourage them. Kavita can encourage them, Dr. Kalapnor can encourage them. It is not like a complaint, it's not like a punishment or anything. It's just I'm not on the board, so I'm going to tell Kavita about this anyway.
Okay.
And
Okay.
Swami, again,
Thank
the problem is about the time. Especially our Indian staffs, they don't have much time to interact with the questions and other things. But for that, we can give the tips like the questions, daily posting questions are available for a week. We are not removing from the group. The questions still available. Use your own time to look into that question. You don't have to do on the same day. We are not removing the question. We know the way you work, the time we are not getting all these things. Considering all these things, we are not removing the question after the day. It's still available for some time. Yeah, use that opportunities only. That is the thing.
Okay,
So,
thank you.
however,
Thanks very much.
we have to give
Thank
vote
you.
of
Thanks to
vote of thanks to
Thank
our,
you.
vote of thanks to our viewers in the YouTube as well. Thank you very much, all the viewers. They are watching in the YouTube, Facebook as well, and the SSIM's hospital as well. Very thankful for your time. So, during your work period, you are all here. And again, great thankful to Jasmin as well.
Thank you.
Wonderful session. Thank you very much on behalf of Gina. And the next sessions, we don't have the next session because of the Easter holidays are coming. So we have to give some time for the people and ourselves to have some time. So there will be no session on next in 3 weeks of time. So we'll let you know when the other section is coming out anyway. Yeah, thank you very much. Thank you, everyone.
Thank you, everyone.
Thank you.
Thank you.
Thank you.
Thank you. And if any manual handling help needed, any advice, you can always contact me as well. I'm part of your team, so nothing to just to please, just anything if I can help with, I can definitely do that.
Thank you, Jasmin. Thank you,
you.
Jasmin. The next session is on 17th of April, tracheostomy management.
Okay. Can I leave it? Can I leave?
Yes, thank you, Jasmin. Thank you so much.
No, I need to speak to Jasmin for a few minutes. Can Jira members and Jasmin can stay back, please?
Okay. Thank you.
Okay. Thanks to all. Thank you.
Thank you.
Thank you.
Thank you.
Jasmin.
Can rest of the members can log out, please?
Hello.
Suresh, I think you have to remove manually.
I think manually.
I'm doing it. Yeah.
Yeah.
Jasmin, we are getting a few good comments in our clinical group. They're expressing their gratitude and they're saying very nice. Thank you, ma'am.
Oh, that's so good. Thank you so much.
Okay, so 2-3 messages came.
Always the feedbacks are really good for us to grow, isn't it? That's good.
Absolutely. Even simple feedback also make a big difference.
Exactly.
Yeah. So there's one person called Renuka. She said, very nice, ma'am. And another person, I don't know, Likita Nandan. And she also said that she or he, I don't know. Very nice. Thanks, ma'am. So
Thank you. Thank you. Thank you so much. Could you please send that in email for me just to, then I can keep for my.
Absolutely. Yeah. I'll send the screen. I'll share that screen.
Yeah.
Okay.
Okay. We are on the 4th year anyway now.
Okay. Thank you, Jasmin. Really nice to see you after a long time.
Oh, thank you. That's so nice.